Welcome back to MLT 120 again. Today we're talking about acute leukemias. We're going to talk about exactly what acute leukemias entails and also some different classifications for acute leukemias. Okay, acute leukemias. So when we're talking acute, we're talking sudden onset or a short period of time. So leukemias, when we're talking about leukemias, what does that mean? We're talking about a malignant disease which affects the bone marrow and blood-forming organs that produce immature or they're going to produce abnormal leukocytes. Leukocytes, remember, are our white blood cells. And again, this is an abrupt onset of disease. We're affecting the leukemic cells and they are dysfunctional. Complications include infections and a hemorrhage. And a hemorrhage is where you have bleeding or loss of blood. There's hypercellular bone marrow, meaning there's a presence of abnormally large numbers of cells present. So they may even be uncountable. There's so many. So you have an increase of 20 to 90% blast at diagnosis or relapse of disease. Okay, let's talk about diagnosis of acute leukemias. So one of the things that we will see are myeloblast or blast, and those blasts may have an inclusion called error rods. And you'll see these error rods in smears, and these inclusions are made up of fused primary granules, and those granules are fused lysosomes that are rich in enzymes. We also use reactivity of cytochemical stains to help classify the type of leukemia and the cell lines that are effective. We also use reactivity of surface cell markers on the cells. We use chromosomal analysis of a patient to help a diagnosis. We use flow cytometry. We've talked about flow cytometry in the past. That's just a process where we run cells past a laser, and the laser helps determine the type of cell, or is a way to identify cells. And almost 80% of patients will present with chromosome abnormalities in acute leukemia. There's a mutation resulting from a chromosomal translocation, which is the transfer of one portion of a chromosome to another. And if you'll look on the left-hand side of this slide, you'll see some examples of the error rods. The arrows are pointing to the error rods, the inclusion that is in the cytoplasm that you can see in your myeloblast in patients with acute leukemia. And they usually are just a thin little stick-shaped inclusion that usually stains purple. Again, those are made up of fused primary granules. Now let's talk about myelodysplastic syndrome. This is something that you need to know about in association with acute leukemia, because about 5 to 10% of acute myeloid leukemia or AML patients have a pre-leukemic presentation called myelodysplastic syndrome or MDS. This usually happens in patients over the age of 50. Patients have anemia or thrombocytopenia, which is low platelets, and monocytosis, which is abnormally high numbers of monocytes. They also have blast percentages of less than 20%. And MDS, or myelodysplastic syndrome, will eventually become AML, or acute myeloid leukemia. Okay, so this is kind of a precursor syndrome which will eventually lead to your acute leukemia. So what if a patient develops into AML or acute myeloid leukemia? So this is a cancer of the blood and bone marrow. It's the most common type of acute leukemia in adults. and in most acute myeloid leukemia patients, the myeloid cells are abnormal or never mature properly. The cells can build up in the blood and the bone marrow, making less room for healthy white blood cells, red blood cells, and platelets. Affected abnormal myeloid cells can spread throughout the blood and other parts of the body. Symptoms of AML patients can include fatigue, recurrent infections, and these patients can also bruise very easily. If you look at the flow chart of the myeloid stem cell on the left side of your screen, you'll see that the maturation sequence for the AML patient, they don't get very far along in the maturation line of your myeloid cells before these patients start having issues with development and maturing or maturation of their blood cells. So you have abnormalities along the way. Next, we need to discuss immunophenotyping. This is a technique used to study protein antigens expressed on cells. So we can help classify a clone of a leukemic blast by using monoclonal antibodies directed against surface markers. So if we know if we think back and know what we know about antigens, antibodies, we know our antigens are stuck to our cells, and our antibodies are like a lock and key system to our antigens. So we can use our monoclonal antibodies to help determine what antigens we have. We also can use fluorescent markers to help ID the type of cell that we have. And we can also use the process of flow cytometry to help determine the type of cells that we have. Remember, we use the laser, and the cells are passed by laser one cell at a time, and that helps determine what type of cell that we have. Some of the different examples of myeloid lineage that we would have markers for are the CD11B. Remember, CD represents cluster destination. Also, we could have the CD13, the CD33, and the CD15. Okay, now we need to talk about some different classification systems for AML, or acute myeloid leukemia. We first need to talk about the purpose of a classification system. The purpose is determining the subtype of AML based on the type of cells and immaturity of the cells. This is important because sometimes it affects both the patient's outlook and the best treatment options for the patient. So that's the reason that we have the classification systems. We actually have two classification systems for our AML, or acute myeloid leukemia subtypes. We have the FAB system, which stands for French, American, British classification. And then we have the WHO classification, which is the World Health Organization classification system. And we're going to talk about each one of these. The FAB classification for AML was established in 1976. It's based on morphology of cells. Later, cytochemistry reactions were added. It's based on blast of greater than 30%. The classifications go from MO to M7. So you start with MO classification, or M0, and you go up to M7. AML with a maturation of M2 is the most common of all AML patients in the FAB classification. There's a chart on page 546 in your textbook that shows all the different classifications, but we're going to go over the key points of each classification in the next few slides. So the first classification for the FAB system is FAB AML M0, and this is an undifferentiated classification, and it's without morphological or cytochemical maturation. This is a primitive leukemic blast classification, and if you look at the image, you can see a lot of blast in the patient sample given here. Next is Fab AML M1. This is myeloid without maturation. You have minimal morphological and cytochemical maturation. Myeloid leukemia cells have primarily myeloblast or blast. Next is Fab AML M2. This is a myeloid with maturation, and this is the most common AML classification for the Fab system. It's characterized by a chromosomal translocation, and it affects the T8 and 21. And we'll talk about what exactly a translocation is a little bit later on in the next lecture coming up. But this classification, the leukemia cells show predominant maturation beyond the blast stage. So we're going a little bit beyond the blast stage in this classification. Next in the Fab classification is M3. This is also known as promyelocytic or acute promyelocytic or APL. You have abnormal hypergranular promyelocytes dominant in these samples. You will also see error rods easily in these patients. They're usually seen in bundles called faggot cells, meaning a bundle of sticks. I know that's not a very nice sounding word, but faggot was used as a Old English term just meaning a unit of measurement for a bundle of sticks. There's an increased evidence of DIC or disseminated intravascular coagulation due to the release of abnormal primary granules that initiate the clotting cascade in these patients. You have chromosomal translocation unique to the M3 classification and the T15 and 17. And again, that's just a chromosomal abnormality. There is a microgranular variant, M3M, and you see indistinct granules, rare to occasional error rods in leukemic cells. They'll have what's referred to as a butterfly nucleus or a nuclear folding that has a bilobed appearance, and this is all for the M3 classification. All right, the next two are AML M4 and 5. For the Fab classification 4, it is a myelomonocytic. You see both myelocytic and monocytic cells and precursors. For the AML 5, it's a monocytic leukemia. Fab classification M6 is an erythroleukemia. It's characterized by abnormal proliferation of erythroid and myeloid precursors. This is an uncommon classification, and this is also referred to as acute Leukemia syndrome, and that's Italian. The last classification for our Fab system is M7. M7 is an acute megakaryoblast leukemia. The megakaryoblast are responsible for the production of our platelets. Megakaryoblast are our platelet precursors, and this is an uncommon classification in the Fab system. Now let's switch over to the WHO classification. This is the World Health Organization's classification system. It was established in 1997. It includes more specific genetic data for classification. It includes separate designations for leukemias that arise from MDS or transition from myeloproliferative disorders. It looks for 20% blast rather than 30% blast in the Fab classification. Remember, our MDS stands for myelodysplastic syndrome, and our myeloproliferative disorders are our disorders that are excess production of bone marrow elements, especially blood and cell precursors. For the 4 classifications for the acute myeloid leukemia for the WHO classification, it starts on page 544 in your textbook if you want to follow along. The first classification is AML with recurrent genetic abnormalities, and you have a translocation. That's what the T stands for, translocation of the 8 and 21, and it's similar to the FAB classification M2 with myeloid maturation. You also can have an inversion. This INV stands for inversion of 16, and this is talking about on the chromosome as well, and has an increase in myeloid and monocytic lines. And then you can have a translocation in the 15 and 17, similar to the FAB classification of APL, or acute promyelocytic, FAB M3 classification. Then for the second classification for the WHO, for AML, you have AML with myelodysplasia. Then for 3, you have therapy-related AML and MDS, or myelodysplasia syndrome. And for the 4th classification, you have AML not otherwise categorized. Okay, to this point we've been talking about AML, acute myeloid leukemia, but let's switch gears a little bit and talk about ALL, or acute lymphocytic leukemias. Okay, so all, or ALL, are predominantly in children between the ages of 2 to 6, and it counts for about 76% of all leukemias diagnosed in children and under the age of 15. And this leukemia is uncommon in adults, but it can occur at all ages. Children with Down syndrome have an increased risk of leukemia. In pediatric age, they have an overall complete remission rate of about 95%. Pediatric meaning children, the age of children, and remission meaning signs and symptoms will go away. So just like with AML, ALL has a classification systems with both the FAB system and with WHO. So let's go over those in the next couple of slides. So with the FAB classification, ALL has 3 categories for the classification system: L1, L2, and L3. And these classifications are based on appearance of blast. The L1 has small blast, L2 has large or mixed sizes, and L3 has large blast. For the WHO classification systems, there's only 2 categories, and it's based on the types, and it depends on if it's a precursor for B cells or if it's a precursor for T cells. The last couple of slides are just some review questions, so I would pause the video at this time, try to answer them on your own before you go on and listen to the answers to the questions. First question, according to the WHO classification, what percentage of blasts must be present in peripheral blood in order to classify the leukemia as acute? The answer would be 20%. Number 2, list some methods used to classify the acute leukemias. The answer would be reactivity with stains, surface markers, and flow cytometry. Number 3, which acute myelocytic leukemia is associated with DIC? The answer would be M3. Number 4, which acute myelocytic leukemia is the most common of the AMLs using FAB classification naming? The answer would be M2. Again, this is just another slide of review questions. Pause it and try to answer them on your own before you go on and listen to the answers. Question number 5. What are arrow rods composed of? The answer is fused granules. Number 6. Which acute leukemia is the most common leukemia in childhood? The answer would be ALL. Number 7. What is the remission rate for childhood ALL? The answer would be 95%. Number 8. list the 3 Fab classification systems for ALL. It would be L1, L2, and L3. Number 9, list the 2 food classifications for ALL. It'd be precursor B cell and precursors for T cells. Number 10, list the 4 main food categories for ALL. It would be Category 1, Category 2, Category 3, and Category 4. This concludes our lecture on acute leukemias and the classification systems of leukemias. I will see you over in the next lecture, but I do want you to know we do have to be aware of these classification systems for the leukemias, but know in your job as a medical laboratory technician, it won't be you as the laboratory technician that are making the diagnosis using these classification systems. You will be looking under the scope and seeing the cells, but it ultimately be the job of the pathologist to determine which classification that the patient will be placed under for a diagnosis.